In 2002, a major clinical trial made international headlines. The study was called the Women's Health Initiative. The headline was terrifying. Hormone replacement therapy causes breast cancer, causes heart disease, causes blood clots. Stop taking it immediately. Now, within months, HRT prescriptions in the United States dropped by more than 50%. Women who had been thriving on hormone therapy stopped overnight. Physicians who had been offering it stopped prescribing it. An entire generation of perimenopausal and menopausal women were denied access to a treatment that could have protected their brains, hearts, bones, and quality of life. Based on a study that, when you actually read it, did not say what the headlines claimed it said. That was 20 years ago, over 20 years ago. The science has moved significantly, and millions of women are still living with the consequences of that one badly reported study. Today, we are correcting the record. Listen, my name is Dr. Tasheema Fair. I am an OBGYN. I'm a hormone health strategist, and this is the Unconventional OB. We're in part 2 of our series on hormonal imbalance for high achieving women over 45. In part 1, we covered the triple hormone decline: estrogen, progesterone, and testosterone, and why executive women are hit harder than most. If you missed it, go ahead and watch it. The link is in the description below. Today, we are going deep on hormone replacement therapy, what the research actually shows, the critical difference between synthetic and bioidentical hormones, your delivery options, the real risk picture and context, and how to have an informed conversation with your provider. Stay tuned. Okay, now let me walk you through what the WHI actually studied, because the gap between the study and the headline is one of the most consequential misrepresentations in modern women's medicine. Okay? The WHI enrolled women between the ages of 50 and 79. The average age of participants was about 63, meaning most of these women had been in menopause or past menopause for like 13 years when they began hormone therapy for the first time. This is a critical detail, and we'll come back to it. The study used conjugated equine estrogen derived from pregnant mare urine, and medroxyprogesterone acetate, a synthetic progestin, not bioidentical progesterone, synthetic progestin, a different molecule with a meaningfully different receptor activity than the progesterone your ovaries naturally produced. The increased risk that generated the headlines for breast cancer, it was an increase of 8 additional cases per 10,000 women per year in a combined estrogen progestin arm of the study. Statistically real, but a very different statement than HRT causes cancer. For context, the increased breast cancer risk associated with drinking one alcoholic drink per day is comparable. The increased risk associated with obesity is significantly higher. The heart disease findings, the increased cardiovascular risk was seen almost exclusively in women who started hormone therapy more than 10 years after menopause. Women who began therapy within 10 years of menopause onset, what researchers now call the critical window or timing hypothesis, actually showed cardiovascular benefit. The study was stopped early. The results were misrepresented in the media, and the nuance, the type of hormone used, the age of initiation, and the route of delivery was lost entirely in the panic that followed. What we now know from over 2 decades of subsequent research, reanalysis of the WHI data, and major studies, including the KEEPS trial, the ELITE study, and the Danish osteoporosis prevention study, is significantly more reassuring. For healthy women who began hormone therapy within 10 years of menopause and before age 60, the benefit risk profile is strongly favorable for the majority. All right. Let's talk about the types of medication. Okay. Before we go further, I want to address the distinction that your conventional provider may never have explained to you, and that changes the entire risk conversation. Okay. Synthetic hormones are molecules that bind to the hormone receptors and produce hormone like effects, but they are not structurally identical to the hormones your body produces. The most common examples are conjugated equine estrogen, the estrogen used in the WHI, and medroxyprogesterone acetate, the synthetic progestin used in Prempro, the specific drug studied in the WHI. Synthetic progestins, in particular, have a receptor binding profile that differs from natural progesterone. They bind to progesterone receptors, but also partially bind other steroid receptors, producing effects that natural progesterone does not produce. The breast cancer risk signal in the WHI was driven by the synthetic progestin arm. The estrogen only arm of the study for women without a uterus showed no increased breast cancer risk and actually trended toward reduced risk. Bioidentical hormones are molecules that are structurally identical to the hormones produced by the human body. Same molecular structure, same receptor binding, same downstream signaling. Bioidentical estradiol, bioidentical progesterone, and bioidentical testosterone. They are derived from plant sources, typically wild yam or soy, and processed into molecules that are chemically identical to human hormones. FDA approved bioidentical hormone options include estradiol patches, gels, and sprays, and oral micronized progesterone. The brand name is Prometrium. Custom compounded bioidentical hormones are also available through compounding pharmacies, offering more individualized dosing and delivery options. Okay. The research on bioidentical estradiol and micronized progesterone, specifically the KEEPS trial and the E3N cohort study in particularly, shows a substantially more favorable safety profile than the synthetic options studied in WHI. The conversation about HRT risk that your provider may be having with you is likely based on WHI data from synthetic hormones. That is not the same conversation as bioidentical hormone therapy. Got it? What are the 3 hormone replacement options? I'm so glad you asked. Let's talk about it. Okay? When we talk about HRT for perimenopausal and menopausal women, we're typically talking about replacing the 3 hormones, the same 3 we covered in part 1 of this discussion. Okay? Estrogen replacement is the primary driver of symptom relief: hot flashes, night sweats, vaginal dryness, sleep disruption, cognitive changes. It also provides cardiovascular protection, bone density maintenance, and metabolic benefits when initiated at the appropriate time. For women who have had a hysterectomy, estrogen alone is used. For women with the intact uterus, progesterone must be added to protect the uterine lining. Progesterone replacement serves 2 purposes: uterine protection in women taking estrogen and independent therapeutic effects, particularly on sleep, anxiety, and mood. Oral micronized progesterone at bedtime is the preferred form for most women because of the GABA modulatory sleep benefits and its superior safety profile compared to synthetic progestins. Testosterone replacement for women remains the most underutilized, underregulated piece of the HRT conversation. There are currently no FDA approved testosterone products specifically indicated for women in the United States, which means providers must prescribe off label, typically using compounded testosterone creams or gels or lower dose versions of male products. Despite this regulatory gap, the research on testosterone in women for libido, energy, cognitive function, muscle maintenance, and mood is compelling and growing. The British Menopause Society and numerous international guidelines now formally support testosterone therapy for women with low levels and compatible symptoms. Okay? Now, different routes of delivery, and we're going to talk about them now. Okay, so how a hormone is delivered into your body is not just a convenience question, it's a safety and efficacy question as well. Okay, oral estrogen is processed through the liver before reaching the bloodstream, a process called first pass metabolism. The hepatic processing increases the production of clotting factors and C reactive protein, which explains the increased blood clot and stroke risk associated with oral estrogen forms. This is a route specific risk, not an estrogen risk. Transdermal estrogen, like patches, gels, sprays, creams, applied to the skin, bypass the liver entirely. It absorbs directly into the bloodstream, delivering estradiol without the hepatic first pass effect. Multiple large studies, including the French E3N study with nearly 100,000 women, have shown that a transdermal estradiol carries no increased risk of blood clots or stroke, unlike oral estrogen. This is a meaningful safety distinction that most women are never told. For women with cardiovascular risk, a history of migraines, or elevated clotting risk, transdermal delivery is strongly preferred over oral. All right. Vaginal estrogen, delivered locally as a cream, a ring, a tablet, addresses genital urinary symptoms like vaginal dryness, painful intercourse, recurrent UTIs, and urinary urgency. A standard standard doses vaginal estrogen has negligible systemic absorption and is generally considered safe even for women with a history of estrogen sensitive breast cancer per current guidelines from the American College of Obstetricians and Gynecologists. Progesterone delivery, oral micronized progesterone is preferred over synthetic progestins in most women. For women who need progesterone but want to avoid the systemic exposure, a progestin releasing IUD such as Mirena provides local estrogen protection with minimal systemic effect. Now, we got to talk about the timing. Now, this may be the most important concept in modern HRT science and one most likely to influence your decision about when to start. Okay? The timing hypothesis, also called the critical window, is supported by multiple lines of evidence and essentially states that the benefits of hormone therapy, particularly cardiovascular and neuroprotective benefits, are greatest when therapy is initiated within 10 years of menopause onset and before age 60. When estrogen is introduced into a cardiovascular system that is still hormonally healthy before significant atherosclerotic plaque has developed, it exerts anti-inflammatory, vasodilatory, and lipid favorable effects. When estrogen is introduced into a cardiovascular system where atherosclerosis is already established, as it was in the older WHI population, the hormone signaling environment has changed and the risk picture is different. The same principle applies to brain health. The WIMS study, a sub-study of WHI, the portion that looked at cognitive outcomes was conducted in women aged 65 to 79. It found increased dementia risk in that population. But the KEEPS Cognitive and Affective Study, which studied women who began HRT within 3 years of menopause, found either neuro or beneficial cognitive effects. The message is clear and it is urgent. If you are in perimenopause or early postmenopause, the window for maximum benefit is right now. Waiting until symptoms are severe enough to justify treatment may mean initiating outside the window for the neuroprotective and cardiovascular benefits that are most accessible. This is not a reason to panic. It is a reason to have a conversation right now, not in 5 years. Got it? Good. All right. Let's talk about some other benefits if you're asking that question. Because most women think HRT in terms of hot flash relief. The framing dramatically undersells what hormone therapy actually does. Let's talk about it. Cardiovascular protection. The Nurses' Health Study and multiple other large observational studies showed that women who initiate HRT in early menopause have significantly reduced rates of heart disease, the number one killer of women. Estrogen maintains arterial flexibility, supports HDL cholesterol, and reduces inflammatory markers associated with cardiovascular risk. Bone density. Estrogen is the primary hormonal regulator of bone mineral density in women. Its decline is the primary driver of the accelerated bone loss that begins in perimenopause and leads to osteoporosis. HRT is the most effective and protective interventions available. And women who cannot tolerate bisphosphonates, it may be the best option. Brain health and dementia prevention. Estrogen supports neuronal survival, synaptic plasticity, and the clearance of amyloid, a protein that accumulates in Alzheimer's disease. The timing benefit evidence suggests that initiating estrogen therapy during the critical window may reduce Alzheimer's risk. For high achieving women who have built cognitive capital across decades, protecting that capital is not optional. Metabolic health. Estrogen supports insulin sensitivity and healthy fat distribution. HRT initiated at perimenopause is associated with reduced visceral fat accumulation, improved insulin signaling, and lower rates of type 2 diabetes. Genital urinary health. Vaginal estrogen prevents genital urinary syndrome of menopause, a progressive condition involving vaginal atrophy, painful intercourse, recurrent UTIs, and urinary incontinence, and significantly impacts quality of life and is almost entirely preventable with local estrogen therapy. Let's talk about the risk, okay? So I want you to understand it. Let me be direct and honest with you about the risk, because informed consent requires the full picture. Got it? Breast cancer. The risk picture depends heavily on the hormone type, delivery route, and duration. Combined estrogen synthetic progestin therapy, particularly oral, is associated with a modest increase in breast cancer risk with long-term use. Estrogen only therapy in women without a uterus shows no significant increased risk. In some studies shows a reduced risk. Bioidentical estradiol combined with micronized progesterone, per the French cohort study of nearly 54,000 women, showed no increased risk in breast cancer compared to non-users. Blood clots. Oral estrogen increases blood clotting risk. Transdermal estradiol does not has established by multiple studies does not increase the risk. Stroke. Similar to clotting, oral estrogen at higher doses carries a modest increased risk. Transdermal estradiol at standard doses does not show meaningful stroke risk increase in low risk women. For women who are not appropriate candidates for systemic HRT, those with active hormone sensitive breast cancer, unexplained vaginal bleeding, active liver disease, or prior blood clot events, there are non hormonal options for symptom management that we will not cover in depth today, but that deserve their own conversation with a specialist. Okay. The bottom line, for healthy women over 60 within 10 years of menopause without contraindications, the evidence strongly supports that the benefits of properly prescribed bioidentical HRT outweigh the risk for the majority. This is now the position of the Menopause Society, the British Menopause Society, and a growing consensus of evidence based menopause specialists globally. Okay? Well, how do you have this conversation? I'm so glad you asked. Here is how you walk into your next appointment equipped. Okay? I'll give you all of it. Find the right provider, first off. A menopause certified physician, an integrative gynecologist, or a functional medicine provider with demonstrated hormone expertise is your best starting point. Okay? And there's a list in the description below. Not all OBGYNs are comfortable with the current HRT evidence base. Finding someone who is trained specifically in menopause management matters. Someone like me. Come with your labs. Before the HRT conversation, have your complete hormone panel in hand. Estradiol, progesterone, total and free testosterone, DHEA, sex hormone binding globulin, FSH, LH, and cortisol. Know what the baseline in is so you can have that conversation. Ask specific questions. Given my hormone levels and symptom profile, am I a candidate for bioidentical hormone therapy? Would you recommend transdermal estradiol over oral given the clotting and stroke risk difference? Can we use micronized progesterone rather than synthetic progestin? Should we also discuss testosterone given my symptoms of reduced drive and energy? Know your window. If you are in perimenopause or within 10 years of your final period, you are in the timing window where benefits are maximum. Do not wait until symptoms become unbearable to start the conversation. Okay? Hope you're getting this. Now, in part 3 of the series, we are going into the full adrenal hormone and cortisol conversation. How chronic stress is actively dismantling your hormonal architecture, what adrenal fatigue actually means clinically, and the protocol for rebuilding your adrenal resilience alongside your sex hormone optimization. If this video gave you language you've been missing, girl, share it with a woman who is still afraid of HRT because of the 20-year-old headline. She deserves the full picture. Drop a comment below. Are you currently on HRT, considering it, or have a fear of it that's kept you away? I want to know where you are and where you need more support, okay? Subscribe to the channel. I'll see you in part 3 of this conversation. You are not built to feel this way, and the science is solidly on your side. In the meantime, in between time, stay healthy and stay vibrant and stay unconventional. I'll see you in the next video. Peace.